Thank you, Winfried, for the introduction. Thank you for the invitation to give this lecture. I will try to share my screen. My apologies that I could not be there physically, but it was impossible to come to Greece this weekend, but I'll try to do my best online. So I will talk about sleep apnea in neuromuscular disorders and in some respiratory disorders. I have nothing to disclose related to this presentation. And for the respiratory disorders, I will limit this presentation to sleep disordered breathing in COPD and asthma patients, as there is not enough time to discuss all the respiratory disorders, but we also have evidence that sleep disordered breathing can have an impact in other respiratory disorders like interstitial lung disease after lung transplantation, and for example, in patients with pulmonary embolism or lung cancer. With regard to sleep disordered breathing in COPD patients, this is usually called the overlap syndrome. I would like first to point out that when we fall asleep, there is a significant impact on the physiology of breathing with an impact on respiratory control, for example, a decrease of the chemoreceptor sensitivity, an impact on respiratory muscle function, for example, upper airway muscles becoming less active and also intercostal muscles becoming less active during rapid eye movement sleep, and an impact on lung mechanics, like, for example, airflow resistance. And these changes occur also in normal subjects, but these changes lead only to subtle differences in hypoxemia or in oxygen saturation and CO2 levels during sleep. But in patients with chronic respiratory disorders, like, for example, severe COPD, these could have a profound impact with development of hypoxemia, hypercapnia, and hypoventilation. And besides these changes, in patients with severe COPD, we also know there is airflow obstruction, there is dynamic hyperinflation and increased work of breathing, and this could contribute to repetitive arousals, ventilatory overshoots, and the development of an unstable breathing pattern during sleep. So not every COPD patient has an increased risk of developing obstructive sleep apnea because we know there are some promoting and protective factors in these patients. And promoting factors include a rostral fluid shift that can occur during sleep, cigarette smoking, presence of skeletal muscle weakness, or the use of certain drugs like corticosteroids. But on the other hand, some of these patients may also be, in a certain way, be protected against the development of obstructive sleep apnea. For example, due to a low BMI, the presence of lung hyperinflation, or a diminishment of rapid eye movement sleep. So that's why we need to make a distinction between certain clinical phenotypes of COPD. And when we look, for example, to the emphysema COPD phenotype associated with low body weight or lung hyperinflation, these patients may be somewhat protected to develop obstructive sleep apnea, while the chronic bronchitis phenotype with elevated BMI and higher likelihood of right heart failure may have a higher risk to have obstructive sleep apnea. Well, is it important that these patients have obstructive sleep apnea? This is a prospective study in adults with suspected OSA, more than 10,000 patients included, and they were divided into 4 groups: those having no COPD and no severe OSA, those only having severe OSA, those with COPD, and patients with a combination of COPD and severe OSA. And if you look to the event-free survival, then you see that the highest mortality is seen in the patients with a combination of COPD and severe OSA. A similar exercise was made for patients with COPD with severe nocturnal hypoxemia. Also, the highest mortality was seen in the group with COPD and nocturnal hypoxemia. So the highest hazard of cardiovascular disease and all-cause mortality was found in individuals with a combination of OSA and COPD. And if they were divided into men and women, it was seen that in women there was a combined effect of nocturnal hypoxemia and COPD on the cardiovascular risk, which was synergetic. How do we evaluate these patients? Well, we have to look for clinical features that are consistent with each disorder, including snoring, witnessed apnea, dyspnea. But we could also look to certain special features like morning headaches, the presence of cyanosis, peripheral edema, and we also should take into account sleep disturbances with fragmented and shortened sleep time. It's important to know that there is no direct evidence for the use of questionnaires to predict OSA in COPD patients. If we have a diagnosis of overlap syndrome, it's important that we treat these patients, and this is a prospective trial looking to positive airway pressure treatment. So 3 groups of patients were studied: patients with COPD, patients with overlap syndrome not treated with CPAP, and patients with overlap syndrome treated with CPAP. And then they were followed up for approximately 10 years. And you can see in red that patients having overlap syndrome and are not treated with CPAP, that they have the lowest survival, and that effective treatment with CPAP reduced mortality in the overlap syndrome patients and made mortality look similar to patients with only having COPD. And this is another retrospective study looking to the impact of positive airway pressure treatment. So here you see overlap syndrome patients all being treated with positive airway pressure. And then a distinction was made between adherent and non-adherent patients. And you can see that adherent PAP usage by patients with overlap syndrome was associated with a reduction of all-cause hospitalizations, all-cause ER visits, severe exacerbations, and healthcare costs. Just one slide to mention that also stable hypercapnic failure can of course be present in COPD patients, and we now have 2 quite large randomized controlled trials evaluating the impact of non-invasive ventilation during the night on these patients. And both studies actually show a good effect of non-invasive ventilation. A first study, the Coneline study, showed that there is a significant decrease in mortality when you treat these patients with nocturnal non-invasive ventilation compared to the control group. And the second study showed that the admission-free survival was significantly improved, again in a group of patients with COPD having stable hypercapnic failure treated with non-invasive ventilation. So let's move to asthma. Here you see results from a meta-analysis including 26 studies showing that the odds of having obstructive sleep apnea is increased with a factor 2.6 in asthmatic patients. And it was also shown that asthma patients with OSA have a significantly higher BMI. But nevertheless, asthma patients seem to have a higher risk to have or to present with obstructive sleep apnea, and several factors are modifying this relationship, like, as I already mentioned, obesity, but also reflux and the presence of rhinitis. This is a study evaluating the incidence of obstructive sleep apnea or new onset of obstructive sleep apnea in patients with or without asthma. And shortly, this study showed that patients with asthma have a higher risk to develop obstructive sleep apnea over the next year. So asthma is associated with an increased risk also of new onset obstructive sleep apnea. And pathophysiologically, this could probably be explained by the fact that obstructive sleep apnea leads, of course, to chronic intermittent hypoxemia, which could on the longer term lead to airway remodeling and could contribute to the development of asthma or obstructive respiratory disorders. Besides this, bronchial hyperreactivity and neutrophilic airway inflammation could also play an intermediate role in this relationship. And the other way around, asthma, due to possible corticosteroid treatment or impact on lung function, could also contribute to the development or presence of obstructive sleep apnea. With regard to treatment of sleep disordered breathing in asthma patients, we know that nocturnal symptoms can significantly improve when we could improve asthma control. So it's important to also adequately treat the underlying asthmatic problem. And then several trials have looked to the impact of CPAP, positive airway pressure, on sleep apnea in asthmatic patients. And you can see that several of these trials have shown that daytime asthma symptoms, risk of having a severe asthma attack, asthma severity, and asthma control could improve when you treat these patients with comorbid obstructive sleep apnea with positive airway pressure. So then I would like to move to sleep disordered breathing in neuromuscular disorders. And I would first like to mention that the term neuromuscular disorder is actually an umbrella including many different individual neuromuscular diseases, and these disorders are usually classified by the location, anatomical location where the problem is situated. For example, problem in the motor neuron is seen in, for example, patients with amyotrophic lateral sclerosis or spinal muscular atrophy. There can be a problem at the peripheral nerve, a problem at the neuromuscular junction, as is seen in myasthenia, or a problem at the level of the muscles, for example, in patients with Duchenne muscular dystrophy or limb girdle muscular dystrophy. If we look to the literature that evaluated the presence of obstructive and central sleep apnea in different neuromuscular disorders, then you can here see a table that summarizes some of these findings, and you see quite high prevalences of obstructive or central sleep apnea in different neuromuscular disorders. But you can also see that for some of these neuromuscular disorders, when we have multiple studies, that the range of these prevalences is quite broad. And this is, of course, due to the included population that has been studied in these different studies, but also due to the different cutoffs or the definitions of obstructive sleep apnea that have been used. Nevertheless, it seems that sleep disordered breathing is quite prevalent in several neuromuscular disorders, and some of these disorders, like for example myotonic dystrophia type 1, are also associated with a higher prevalence of having central sleep apnea rather than obstructive sleep apnea. But maybe for the most progressive neuromuscular disorders, another problem is more important, which is the development of progressive respiratory failure with development of nocturnal hypoventilation or even daytime hypoventilation when these neuromuscular disorders progress further. And this is an excellent trial giving a brief overview of different types of respiratory failure that we can see in different types of neuromuscular disorders. And for example, at the top left here, we see some neuromuscular disorders like Guillain-Barré syndrome and myasthenia that are associated with development of acute respiratory failure. We have other disorders that are rather associated with development of variable, slowly progressive respiratory failure, like, for example, myotonic dystrophia type 1, limb girdle muscular dystrophy, post-polio syndrome, and mitochondrial myopathies. And then we have other neuromuscular disorders that are characterized by a rapidly progressive or fatal course of respiratory failure, like amyotrophic lateral sclerosis or spinal muscular atrophy type 1. So why do we see respiratory failure in these progressive neuromuscular disorders? Well, a very important factor is, of course, the development of respiratory muscle weakness. And if we have inspiratory muscle weakness in these patients, tachypnea will develop, and this will increase the demand and the work of breathing and will also lead to a reduction of the blood flow to the respiratory muscles, which could lead to respiratory muscle fatigue and induce hypercapnic respiratory failure. On the other hand, inspiratory muscle weakness could also lead to a decrease of tidal volumes, possible development of atelectasis with, again, an impact on hypercapnic respiratory failure, but also due to ventilation perfusion mismatch and hypoxemia to hypoxemic respiratory failure. And we should not forget the component of expiratory muscle weakness, which will impair cough and lead to a reduction of clearance of secretions, which could also contribute to atelectasis and ventilation perfusion mismatch. So in these progressive neuromuscular disorders, we see a course of respiratory failure starting at a certain point, and the first or the highest chance of seeing first signs of respiratory failure is during rapid eye movement sleep, due to the fact that we have these changes during sleep on our respiration with decreased chemosensitivity, increased upper airway resistance, and the fact that during rapid eye movement sleep, there is an increased diaphragm burden because there is a reduced activity of the intercostal muscle and other respiratory muscles. So this is an example of one of our ALS patients where we see the first glimpse of respiratory failure during sleep. You see here the thick line are the REM episodes. You see that the nocturnal oxygenation is quite stable, and here you see the transcutaneous CO2 at the bottom, and you see that only during rapid eye movement sleep there is a slight elevation of the CO2, meaning the first occurrence of respiratory failure here only during REM sleep episodes. So if we want to evaluate these patients and determine the onset of respiratory failure and also determine the timing of the start of possible non-invasive ventilation, we should assess these patients, and therefore we can use, of course, symptoms. And here you can see some symptoms. We can ask for the presence of fatigue, poor concentration, confusion, breathlessness, orthopnea, the presence of recurrent chest infections, but certainly also ask for sleep-related symptoms like disturbed sleep, non-refreshing sleep, daytime sleepiness, and morning headaches, as we see the first occurrence of respiratory failure during sleep. Some groups have developed specific questionnaires that could predict the timing or the onset of respiratory failure. This is just an example of one of these questionnaires. You see here the sensitivity, if the score is higher than 2, but even these authors mention that we actually should combine these questionnaires with lung function testing. And indeed, we have a whole array of possible diagnostic methods that we also routinely use to evaluate the timing of the onset of respiratory failure. And these diagnostic methods include lung function with a vital capacity, respiratory muscle testing, the maximal inspiratory pressure, the sniff nasal inspiratory pressure can be used to test respiratory muscle weakness. Nowadays, we can also use diaphragm ultrasound to look to the movement of the diaphragm, but here no standardized cutoffs have been established yet. We can, of course, do nocturnal measurements like nocturnal pulse oximetry to evaluate oxygen saturation during the night, or perform nocturnal transcutaneous CO2 measurements to evaluate CO2 levels. Or, if in doubt, we can perform a polygraphy or a polysomnography to test the sleep structure in these patients and, of course, also the gas exchange during sleep. For the expiratory muscles, we can do a maximal expiratory pressure or a peak cuff flow. And of course, arterial blood gases can also be helpful, but if you have hypercapnia on an arterial blood gas during daytime, we are all already quite advanced in the development of respiratory failure, as already mentioned, the first occurrence will be during sleep. So here you can see some guidelines of different groups about the start or the initiation of non-invasive ventilation in these patients with progressive neuromuscular disorders. And you can see that most of these guidelines include the diagnostic methods that we have discussed in the previous slides. There are some slight differences between the different guidelines, but usually a cutoff of a forced vital capacity of less than 50% or sometimes less than 80% with clear symptoms is used to start non-invasive ventilation in these patients with progressive neuromuscular disorders. We know in ALS there is a randomized controlled trial available that non-invasive ventilation has an impact on survival. There was a significant improvement of survival in this study from Burke in ALS patients starting with non-invasive ventilation. And here at the bottom you see some work from our sleep lab where we showed that after the start of non-invasive ventilation there is a clear improvement in sleep architecture, with before the start of non-invasive ventilation, absence of slow wave sleep, absence of rapid eye movement sleep, and significant desaturation. And after the start, you see reoccurrence of slow wave sleep and rapid eye movement sleep, so a significant improvement of the sleep architecture. When we treat patients with non-invasive ventilation, it's of course also important to monitor these patients to see whether we achieve the goals that we want to reach. And we can use different tools to monitor our patients, and the best tools are, the discussion on the best tools is still open. But here you can see some guidance on this monitoring, where we of course have to look to the clinical improvement of our patients. But this author also proposed to use nocturnal oxygen saturation measurement, and certainly also the use of data from the non-invasive ventilator itself, so from the software, where we can see flows, leaks, and so on, and this can help us to improve the non-invasive ventilation treatment. So if you see changes, then you should try to change or optimize the settings or the mask fitting. If there are still abnormalities after the optimization, then it is recommended to perform a nocturnal evaluation with polygraphy or polysomnography. And this is just an example, again, of one of our patients. We have the opportunity in our sleep lab to incorporate the data from the ventilator software in our polysomnography signals. So here you see the pressures at the top off from the ventilator. You see the flow from the ventilator, the second line, and then you see the chest and abdominal movements. And here, these respiratory events are quite frequently seen in patients with ALS, where you see a reduction of flow. So there is a reduction of flow with absence of respiratory effort. So you could maybe think this is a kind of central event. But on the other hand, the ventilator is giving pressure support while no air is going into the lungs of the patient. So there should also be an obstructive component. And these events are described in the literature as obstructive events with a reduction of the drive to breathe, which is quite often seen in ALS. And some studies also have shown that this could have an impact on survival or outcome of these patients. So if we see certain problems, we should try to solve this. When we see obstructive airway events, we can increase the expiratory pressure, or we can switch from an oronasal mask to a nasal mask to try to optimize these obstructive events. Or we can switch from even pressure ventilation to volume ventilation or reduce the inspiratory time. If we have mask leaks, we should, of course, optimize mask fitting. And if you have other problems like hypoventilation, you should try to improve the pressure settings or the other ventilator settings. What is also important is that patients and caregivers are adequately trained on technical equipment at home, and also having received advice on problem solving when these problems occur during the treatment at home. And of course, in progressive neuromuscular disorders, anticipatory planning and palliative care discussions are highly important. So I would like to conclude, sleep represents a vulnerable state for patients with different respiratory and neuromuscular disorders. For COPD patients, management of sleep disordered breathing includes positive airway pressure treatment, as positive effects on survival and healthcare costs were shown. For asthma, we know that there are common risk factors between sleep disordered breathing and asthma, including rhinitis, reflux, and obesity, and treatment of OSA may also improve asthmatic control. And for neuromuscular disorders, development and progression of respiratory failure is highly variable in different disorders. These patients should be screened for nocturnal hypercapnia, as this is the first stage where respiratory failure will develop, and the efficacy of non-invasive ventilation should be evaluated using objective assessments. So thank you for your attention.